Just like with the acute leukemias, there are two general types of chronic leukemias based on the type of neoplastic progenitor cell that's present: myeloid or lymphoid. Unlike acute leukemias, however, chronic leukemias involve an abnormal proliferation of mature or maturing cells rather than blasts or promyelocytes. Yeah, our last sketch covered acute leukemias, and it was cute and all, but it's time for some serious art. Take this piece in the center here, huh? What do you think? Okay, interesting opinion, though misguided. It's clear to me that the aura of the purity line spatially undermines the exploration of montage elements. Though, with regard to the issue of content, the internal dynamic of the negative space threatens to penetrate the. Oh, wait, that's just a clock. Anyways, compared to the acute leukemias, chronic leukemias may present with a more insidious onset and may be asymptomatic at diagnosis. And in the center of this sketch, we've included our recurring symbol for chronic disease, an old grandfather clock. As indicated by the signs above, we're going to cover chronic myeloid leukemia in the modern myeloid area on the left, followed by chronic lymphocytic leukemia over in the late lymphocytic hall to the right. Chronic myeloid or myelogenous leukemia, abbreviated CML, is a myeloproliferative neoplasm caused by the unregulated clonal proliferation of mature and maturing granulocytes. At Sketchy, we depict granulocytes as blue, white, and pink dots symbolizing basophils, neutrophils, and eosinophils respectively. Kinda like the Bend-Aid dots in this painting here. Neutrophils are usually the most dominant. And unlike the acute leukemia sketch, which featured crude amateurish splotches of paint representing immature cell types, this sketch features nice, neat, round dots, conveying an image of mature, differentiated cell types characteristic of chronic leukemia. It should be noted that these cells may be morphologically normal, i.e., they have a normal appearance in terms of shape, structure, form, and size, but are cytochemically and functionally abnormal. CML progresses through three disease phases: chronic, accelerated, and blast. Most patients are diagnosed during the chronic phase, during which disease is more insidious and often asymptomatic. Untreated chronic phase CML progresses to an accelerated phase in 3 to 5 years. The accelerated phase is characterized by progressively impaired neutrophil differentiation and refractory leukocytosis. Not to sound mean or anything, but the left side of that painting is looking a little rushed. Accelerated, if you will. And as a result, the basophil, neutrophil, and eosinophil dots are more splotchy and less differentiated. Slow down there, buddy. And finally, the blast phase resembles acute leukemia and is characterized by an uncontrolled proliferation of myeloid or lymphoid blasts, symbolized here by these amateurish crude splotches of paint. Just immature, to say the least. Chronic myeloid leukemia accounts for 15% of leukemias in adults with a median age of 65 at diagnosis. However, CML does occur in all age groups. Let's talk about clinical presentation. As I just mentioned, CML is usually diagnosed in the chronic phase. Many patients are asymptomatic and diagnosed incidentally based on routine laboratory testing. Just look at this Liechtenstein fan over here, giving the thumbs up, happy and symptom free. Her husband, though, not so much. Nonspecific symptoms of CML include fatigue, malaise, weakness, drenching night sweats, and weight loss. These symptoms are typically more insidious in the chronic phase of CML, but become more severe in advanced phase disease. CML typically involves splenomegaly due to extramedullary hematopoiesis, hence the large splenic guitar in the painting back there. If the enlarged spleen compresses the stomach, patients may experience early satiety and weight loss. Patients will often describe feeling full prematurely despite having a good appetite. Splenomegaly can also cause abdominal fullness and distension. Patients may report left upper quadrant pain or discomfort, sometimes referred to the left shoulder, as a result of the enlarged spleen. In some cases, splenomegaly may even cause splenic infarct because of insufficient blood supply to the overwhelmingly enlarged spleen. Inflammation of the splenic capsule, aka perisplenitis, can also occur. Patients with CML may describe bleeding, including epistaxis, bleeding gums, and, as highlighted by the spots on the bench here, petechiae. This is thought to be secondary to platelet dysfunction, which is kind of counterintuitive considering that these patients often have thrombocytosis, or too many platelets. Alas, though they are plentiful, these platelets are not functioning normally. Kind of the theme here with CML. Patients in the accelerated and blast phases of CML begin to present with symptoms more similar to acute leukemia. I knew I recognized that guy. Yeah, I see him all the time over at Cute Luke Ceramics, the setting of our acute leukemia sketch. Symptoms of acute leukemia are primarily a result of cytopenias: fatigue from anemia, bleeding and petechiae from thrombocytopenia, as well as infections and fever from neutropenia. Patients may also have bone pain as leukemic cells expand into the bone and periosteum. Exposure to ionizing radiation, like an atomic bomb or nuclear reactor explosion, is the only known risk factor for CML. So, moral of the story here: stay away from explosions. Alright, because most patients are asymptomatic, nothing beats a thorough physical exam. Well, labs do, I guess, but physical exam first. Splenomegaly is the most consistent physical sign at diagnosis of CML, present in 50 to 60% of patients. So check to see if that spleen tip is palpable with deep expiration and estimate how many centimeters the spleen tip is below the left costal margin. The size of the spleen is a very important prognostic factor and correlates to the white blood cell count. In CML, splenomegaly typically worsens as the disease progresses to the advanced stage, with increased risk for splenic infarction and or perisplenitis. Petechiae, or purpura if greater than 2 millimeters in diameter, are non-blanching reddish-purple spots on the skin. In CML, their presence typically signifies an underlying platelet dysfunction and increased bleeding. In patients in the accelerated and blast phases of CML, you may see signs similar to acute leukemia on physical exam. Assess for lymphadenopathy, hepatosplenomegaly, and worsening splenomegaly, signs that disease is spreading beyond the bone marrow throughout the lymphatic system. Alright, enough hands on time. Let's get some labs. One of the most important laboratory studies in the diagnostic workup of CML, or really any leukemia, is a CBC with differential. Marked leukocytosis, with a white blood cell count often greater than 100,000 per microliter, is a common feature of CML. And as I mentioned previously, white blood cell count actually correlates with the spleen size. The differential will typically reveal granulocytes, particularly neutrophils, as the predominant leukocyte type. And since neutrophils are like the first responders of the immune system, we've brought in a couple EMTs carrying away a damaged painting. Neutro first responders, if you will. Eosinophils can also be elevated. Not surprising, this being a myeloid leukemia and all. And check those basophils too. Absolute basophilia is a universal finding in CML. The basophilia increases in the accelerated stage, and patients can develop symptoms such as pruritus, as well as upper GI ulcers and bleeding because of all that histamine being released from those granulocytes. Why the pale face? Well, because of that crowded bone marrow, a mild normochromic normocytic anemia is often seen in patients with CML. Anemia can worsen in advanced phases. Ah, stacked plates. Sophisticated art, or just edgy to the point of banality? One thing I do know is that it's a recurring symbol for elevated platelet count, or thrombocytosis. In fact, patients with CML often present with platelet counts soaring over 600,000. Keep in mind, though, that platelet counts can be normal. Low platelet counts, or thrombocytopenia, may be seen in advanced phase CML, but are not typically seen in chronic phase. In fact, if thrombocytopenia is present at diagnosis, consider etiologies other than CML, such as a myelodysplastic syndrome. The clinical hallmark of CML is the uncontrolled production of mature and maturing granulocytes, and this is demonstrated on the peripheral smear. Expect to see lots of cells from the neutrophilic series specifically, with all stages of myeloid maturation present, as illustrated in this painting of a cityscape. From left to right, we can see the early stages of neutrophil development: promyelocyte, myelocyte, and metamyelocyte. Notice the left shift, however, with a greater percent of myelocytes than the more mature metamyelocytes. This is dubbed the leukemic hiatus or myelocyte bulge and is represented by the myelobuilding in the center, which is tallest. Keep in mind that, in the chronic phase, these cells appear morphologically normal. However, looks are deceiving. because these neutrophils are actually cytochemically and functionally abnormal. But more on that later. Since we're talking about the smear, I also want to point out that, in the chronic phase, blasts should account for a low percentage of cells. Blasts are a feature of advanced phase CML, however. As CML disease progresses, the neoplastic cells lose their ability to differentiate, and so more immature blast forms are seen. Accelerated phase is characterized by the presence of 10 to 19% blasts, and the blastic phase is greater than 20% blasts. These can either be myeloblasts or lymphoblasts. In about two-thirds of patients, the blastic phase resembles acute myeloid leukemia, while in the other one-third of patients, the blast phase looks just like acute lymphoid leukemia. Bone marrow biopsy for morphological and cytogenetic evaluation is a recommended diagnostic study. However, if a bone marrow biopsy is not feasible, a peripheral blood specimen is acceptable to confirm the diagnosis of CML. Bone marrow findings reflect those of the peripheral blood, with a hypercellular bone marrow demonstrating granulocyte hyperplasia with cells in all stages of development. Again, we look for blasts. Remember, in the chronic phase, blasts account for a low percentage of cells in the marrow, while the accelerated phase is characterized by the presence of 10 to 19% blasts, and the blastic phase is characterized by greater than 20% blasts. Additional bone marrow findings can include increased collagen and reticulin fibrosis. For definitive diagnosis, we can perform genetic testing for the Philadelphia chromosome. The Philadelphia chromosome, the hallmark of CML, is present in all patients. But notice that the shipping box is also labeled breakable. In most cases, the Philadelphia chromosome is created from a 922 translocation, which causes fusion of the BCR gene on chromosome 22 and the ABL gene on chromosome 9. What you end up with is the BCR ABL fusion gene, which produces a constitutively activated receptor tyrosine kinase. It's this dysregulated tyrosine kinase activity that underlies the pathogenesis of CML. We can use karyotyping or FISH analysis or RT-PCR to detect the Philadelphia chromosome itself, the BCR ABL gene, or the mRNA product of the gene. As we mentioned earlier, your first inkling that a patient may have CML often comes from routine lab results. So, when your patient presenting with weird, nonspecific symptoms comes in with a scary looking CBC, what else should be on your differential? If you said leukemoid reaction, then you've been paying attention. The super high white blood cell counts produced in leukemoid reaction can definitely scare any physician into thinking leukemia, but there are a few important differences between the two conditions. First, check a leukocyte alkaline phosphatase level. Since leukocyte alk-phos is only found in mature white blood cells, it'll typically be elevated in leukemoid reaction, whereas patients with CML will have an abnormally low LAP level. Second, while absolute basophilia is a universal finding in CML, it's almost never seen in patients with leukemoid reaction. Finally, in super equivocal cases, test for the presence, or lack of, the BCR ABL1 fusion gene. If you see it, it's CML. If not, it might just be leukemoid reaction. The other big condition to keep in mind is acute myeloid leukemia. That's because when patients with CML progress into blast crisis, their clinical and laboratory presentations can look virtually identical to that of AML. In these cases, you'll have to look for the presence or absence of the BCR ABL1 fusion gene to figure out which type of leukemia your patient has. Making the distinction is super important because CML can be very effectively treated with tyrosine kinase inhibitors, which we'll get into in a moment. Since chronic myeloid leukemia is considered one of the 4 classic myeloproliferative neoplasms, it stands to reason that the other 3, that is, polycythemia vera, essential thrombocythemia, and primary myelofibrosis, should be on your differential when you're thinking CML. Fortunately, these other conditions have classic features that quickly distinguish them from CML. In polycythemia vera, the increased hemoglobin and hematocrit give it away. In essential thrombocythemia, it's a super high platelet count, typically over 1 million. Finally, in primary myelofibrosis, it's, well, fibrosis on the bone marrow biopsy. If you're still stumped, however, just look for the BCR ABL1 fusion gene. Most other non-CML myeloproliferative neoplasms won't have it. Sensing a pattern here? Finally, myelodysplastic syndromes can also present with similar symptoms of anemia, bleeding, and infections due to cytopenias. They are typically slow growing cancers that are caused by the clonal proliferation of damaged bone marrow cells. While a bone marrow biopsy is ultimately needed for diagnosis, MDS has a few features that aren't typically seen in CML. First of all, MDS usually presents with leukopenia, whereas white cell counts reach 6 digits in CML. Secondly, MDS also typically causes thrombocytopenia rather than the slight thrombocytosis of CML. Of course, if you're ever in doubt, test the bone marrow biopsy for the BCR-ABL1 fusion gene. Let's sum up the presentation of CML in a sample assessment statement. Ima T is a 58-year-old woman presenting with fatigue and excessive sweating over the past 2 months. Physical exam is significant for mucosal pallor and splenomegaly. Labs are significant for a hemoglobin of 8.5, platelet count of 620, and white count of 72. The peripheral smear is significant for immature neutrophil precursors, including more myelocytes than metamyelocytes. These lab results, along with the myelocyte bulge, are concerning for chronic myeloid leukemia. The treatment of CML depends on the phase in which the patient presents: chronic, accelerated, or blast crisis phase. Tyrosine kinase inhibitors, such as imatinib, are the initial treatment of choice for most patients with CML. Just think of this kid here, making a mocking gesture with his hands, imitating passersby, if you will, a recurring symbol for imatinib. Although these drugs are not curative, they can often induce long term remission, especially in patients with chronic phase CML. CML in accelerated phase or blast crisis is much more difficult to control. These patients are typically pre-treated with a tyrosine kinase inhibitor to revert them to a chronic phase before undergoing allogenic hematopoietic stem cell transplantation. Allogenic means the stem cells come from an HLA-matched donor, versus an autologous transplant in which the donor's own stem cells are transplanted. Allogenic transplant remains the only treatment option with proven ability to cure CML. However, it's associated with increased short and long term morbidity and mortality, despite the possibility of cure. Thus, allogenic transplant is rarely offered as initial therapy. For more info on allogenic versus autologous hematopoietic stem cell transplant, check out our acute leukemia sketch. For patients who are not transplantation candidates or are intolerant or refractory to treatment with tyrosine kinase inhibitors, chemotherapy can be of benefit. Well, that about does it for chronic myeloid leukemia. Can't say I was too impressed, really. Modern art just isn't my thing, I guess. Medieval art, on the other hand? That's what I'm talking about. What with the weird perspective and total lack of dimension and a plethora of little man faced baby Jesuses, you can't go wrong. It's time to illustrate the lymphocytic version of the story. Chronic lymphocytic leukemia, or CLL, is a neoplasm characterized by the progressive accumulation of monoclonal, functionally incompetent B lymphocytes. It's like you have a bunch of dumb, incompetent B cells just obliviously wandering around your circulation. These are mature lymphocytes, mind you. It's just that they have defects in cell signaling and are unable to develop into antibody producing plasma cells. To remind you of B cells, this medieval painting features antibody archers with B shaped bows dressed in white. Also, see how it's kinda symmetrical? Almost like they're clones of each other? And lastly, remember that these are incompetent B cells. I mean, come on, just look at that shading and weird lack of perspective. Incompetent is a little harsh, I guess, but can the Renaissance get here already? You know what I mean? CLL is considered to be a part of the same disease spectrum as small lymphocytic lymphoma, or SLL, and indolent B cell non Hodgkin's lymphoma. At Sketchy, we represent lymphoma with the chessboard crowded with white antibody archers, just like a lymph node overrun with neoplastic B cells. The difference between CLL and SLL is that, in CLL, the disease manifests primarily in the blood. That's why we call it leukemia. In SLL, on the other hand, the bulk of the disease is in the lymph nodes and lymphoid tissue. Unless otherwise specified, we'll use the term CLL to indicate both chronic lymphocytic leukemia and small lymphocytic lymphoma as one disease entity. CLL is the most common leukemia in adults, accounting for approximately 25 to 30% of all leukemias in the United States. As he finally understands the enigmatic sculpture in front of him, notice that he's holding up the one finger for number one leukemia. By the way, sir, way ahead of you on that one. That's literally just a clock. Don't be fooled. CLL is a disease of older adults, with a median age of 70 at diagnosis, and is more common in men than women. Most patients are asymptomatic at diagnosis, which is why he's smiling and symptom free. These patients will have lymphocytosis seen on routine blood count, for example, leading them down the path to diagnosis. Other patients may present with generalized or localized painless lymphadenopathy. They may describe that the lymph nodes get bigger or smaller but don't go away entirely. This waxing and waning characteristic is depicted in these dimmable light nodes. As with CML, CLL can present with symptoms related to splenomegaly, including early satiety, abdominal fullness, and anorexia leading to weight loss. 5 to 10% of CLL patients present with the typical B symptoms of lymphoma, including extreme fatigue, weight loss, fevers, and drenching night sweats. Man, this guy just really doesn't enjoy art. Philistine. Even though there are a large number of B lymphocytes, they're abnormal and don't function properly. Kinda like my dating life. Not only that, they actually inhibit the function of the body's normal B cells. This leads to increased susceptibility to infections. Also, oddly similar to my dating life. The major immune deficiency seen in patients with CLL is a defect in humoral immunity due to hypogammaglobulinemia. Yup, no B cells, no antibodies. This is portrayed by the torn antibody pattern on the bench. Patients are particularly vulnerable to common bacterial infections, so we've added some bacterial beads to the bench as well. Hypogammaglobulinemia is also classically associated with increased infections from encapsulated organisms such as strep pneumo and H. flu. Because without functioning B cells, you can't make the IgGs required for opsonization. Studies have also shown decreased IgM and IgA at mucosal surfaces. The respiratory tract, for example, is a common site of infection. CLL can become more acute if it transforms into an aggressive diffuse large B cell lymphoma, depicted by this diffusely large B cell archer dwarfing the rest of the field. This process is called the Richter transformation and has a poor prognosis. Patients present with worsening lymphadenopathy and B symptoms and deteriorate quickly. Family history is a risk factor for CLL, with a higher incidence in patients with affected first degree relatives. Alright, let's get to vitals and physical exam. Remember that patients with CLL may present with a fever as a part of the complex B symptoms, but keep in mind that these patients may be immunocompromised. So, if a fever's present, always work up infection. As previously discussed, lymphadenopathy is the most common abnormal physical exam finding seen in CLL. Axillary, cervical, and supraclavicular nodes are commonly affected and are firm, mobile, and non tender. Remember, the spleen and liver are lymphoid organs too. Hepatomegaly and splenomegaly, especially, are common presenting features. So get in there and feel around. And while she plays that liver shaped contala, she signs a little medieval ditty, likely Gregorian. Let the open mouth remind you to check for involvement of Waldeyer's ring in the pharynx, which can show up as enlarged tonsils. Some patients with CLL will develop a warm agglutinin autoimmune hemolytic anemia. Again, it's not the neoplastic B cells making these antibodies. Instead, those abnormal B cell jerks are altering the functions of the body's normal B cells, which proceed to attack RBCs with reckless abandon. Symptoms of autoimmune hemolytic anemia include severe pallor, tachycardia, cardiac decompensation, and splenomegaly. Alright, lab time. One of the first tests you should order for a patient with suspected leukemia is a CBC with differential. In the case of CLL, expect to see an elevated white blood cell count. Makes sense. We've got a plethora of mature yet inept monoclonal B cells filling the serum. So, with that in mind, check out the differential, where you'll find a predominance of lymphocytes specifically. The diagnosis of CLL requires a B lymphocyte count in the peripheral blood greater than or equal to 5,000 per microliter for at least 3 months. So, underneath our B lymphocyte tapestry, we've incorporated the number 5,000. Don't be surprised, however, to see much higher counts. In fact, that absolute lymphocyte count is often elevated over 100,000 per microliter. So, obviously, that's the major finding on the CBC. But other cell lines will be affected as well. This time, we're looking for low counts. Anemia may be secondary to that autoimmune hemolytic anemia we described earlier. About 10% of patients will develop clinically significant hemolysis, though usually later in the course of disease. The direct antiglobulin test, or Coombs test, can help diagnose a warm autoimmune hemolytic anemia. Hence the Coombs coonskin cap on that fallen statue. Keeping with that autoimmune theme, turns out that the immune system can get confused and target platelets as well. About 2 to 3% of patients will present with an immune thrombocytopenia. And thirdly, always check that neutrophil count. Yup, even though the B lymphocytes are high, it's getting pretty crowded in there. And in rare cases, patients with CLL develop agranulocytosis, represented, as usual, by the falling granules of a sand timer. Remember that any patient with fever and neutropenia requires immediate blood culture, antibiotics, and a workup for infection. Speaking of infection, recall that about 1 in 4 patients will have hypogammaglobulinemia at presentation. Usually IgG, IgA, and IgM are decreased, putting patients at risk for serious bacterial infections. On the peripheral smear in CLL, you'll see lots of B lymphocytes, of course. And the thing to remember here is that they look like your regular old small blue lymphocytes with narrow borders of cytoplasm and dense nuclei, which we've illustrated in the book. Some lymphocytes may appear smeared on the slide. These are called smudge cells. Hence the smudged ink on this priceless artifact here. Smudge cells are pathognomonic for CLL. Flow cytometry is used to look for B cell markers and to confirm monoclonality. CD5, CD19, CD20, and CD23 are markers specific to lymphocytes. So we have our diagnosis. It requires 1. A B lymphocyte count of at least 5,000 per microliter in the peripheral blood, 2. That typical small blue mature B cell morphology under the microscope, and 3. Confirmation that these are, in fact, monoclonal B cells via flow cytometry. If the B lymphocyte count in the peripheral blood is less than 5,000 per microliter, we can still make a diagnosis with the help of a bone biopsy. That is, if the patient has a cytopenia and a bone marrow biopsy shows an infiltration with typical CLL cells. The idea here is that the bone marrow infiltrate is likely causing the cytopenia. And since we're talking about biopsies, also keep in mind that the SLL variant is characterized by lymphadenopathy and not as many monoclonal B lymphocytes in the blood. To make the diagnosis, we biopsy an affected lymph node or other involved tissue and look for CLL cells. As mentioned earlier, most patients diagnosed with CLL are completely asymptomatic at presentation. The only clue is a routine CBC showing absolute lymphocytosis. With that in mind, let's look at some of the other causes of lymphocytosis you should keep on your differential. Lymphocytosis is a common finding in many infections, such as infectious mononucleosis, pertussis, and HIV. That said, the lymphocytosis caused by infections is typically transient, which is a key distinction since the diagnosis of CLL requires sustained lymphocytosis over at least 3 months. That's why it's important to get follow-up CBCs to see if your patient's lymphocytosis normalizes. Lymphomas should also be high on your differential. Many types of lymphoma can present very similarly to CLL, with lymphadenopathy and constitutional symptoms. That said, lymphomas typically don't cause the absolute lymphocytosis that's required to diagnose CLL. In those equivocal cases where you're unsure, immunophenotyping by flow cytometry will distinguish these different neoplasms from each other. The characteristic pattern of findings in CLL, expression of CD5, CD19, CD23, and lack of surface membrane immunoglobulin, won't be seen in any other type of leukemia or lymphoma. For more details on the clinical presentation and diagnosis of lymphomas, check out our sketches dedicated to them later on in this chapter. Let's leave lymphomas behind and circle back to leukemias for a sec. One type of leukemia that can mimic CLL is hairy cell leukemia. Like CLL, hairy cell leukemia produces peripheral lymphocytosis, so it should always be on your differential whenever you're suspecting CLL. Unlike CLL, however, hairy cell leukemia does not present with lymphadenopathy. But, just as with lymphomas, if you've got a borderline case and you're unsure, immunophenotyping will distinguish hairy cell leukemia from CLL. Look for expression of surface membrane immunoglobulin, which wouldn't be seen in CLL, and lack of CD5 expression, which would be seen in CLL, to push you towards a diagnosis of hairy cell. We'll come back to hairy cell leukemia in just a moment. For now, there's one last disease to consider on your differential: acute lymphoblastic leukemia. Patients with ALL can present similarly to those with symptomatic CLL. However, as its name suggests, ALL produces lymphoblasts on peripheral smear or bone marrow biopsy, whereas CLL should not. Let's summarize the clinical presentation of CLL in a sample assessment statement. C.L. Lewis is a 66-year-old man presenting with cough and fever for the past 4 days. Vitals are significant for a temp of 38.5, heart rate of 96, respiratory rate of 22, and an O2 sat of 91% on room air. Physical exam is significant for inspiratory crackles at the right apex, hepatosplenomegaly, and non-tender cervical lymphadenopathy. Peripheral smear is significant for many lymphocytes, spherocytes, and smudge cells. Labs are significant for a hemoglobin of 10, platelet count of 100, white count of 45, and an absolute lymphocyte count of 38,000. While Mr. Lewis's acute illness is most likely a right upper lobe pneumonia, his lymphadenopathy, hepatosplenomegaly, and lab findings are concerning for chronic lymphocytic leukemia. Like CML, the treatment of CLL depends on the stage of disease in which the patient presents. For patients with early stage asymptomatic CLL, the standard of care is observation rather than immediate treatment. That's because, without treatment, many of these patients still have similar survival rates to the normal population. Additionally, prospective randomized trials have found no improvement in long-term survival with early treatment in CLL. During the observation period, patients are monitored with regular blood counts and clinical examinations to evaluate whether the patient has progressive disease requiring treatment. In contrast, patients with localized SLL, the lymphoma version of CLL, can receive radiation therapy of the involved region. Patients with advanced stage CLL have much shorter survival rates. Therefore, these patients are offered treatment with chemotherapy. Patients with progressive disease or symptomatic disease are also treated with chemotherapy. These patients are often described as having active disease, signs of which include constitutional symptoms, progressive increase in the size of lymph nodes, worsening anemia or thrombocytopenia, rapidly increasing lymphocytosis, extranodal involvement, or repeated episodes of infection. There is no agreed upon single treatment regimen for all patients with symptomatic CLL or advanced SLL. Therefore, selection of treatment is based on individual patient characteristics and goals of therapy. With the possible exception of allogenic hematopoietic stem cell transplantation, CLL cannot be cured by current treatment options. Transplant is an emerging therapy, usually performed as a part of a clinical trial. Alright, the last chronic leukemia on our list is hairy cell leukemia, a rare chronic B cell lymphoid neoplasm caused by the proliferation of small mature B cells. And as you can see, our last painting features a mature adult B cell archer next to his hairy prey. Although it arises from lymphoid cells like CLL, hairy cell leukemia has a unique cell morphology, which we'll illustrate in just a bit. In the setting of hairy cell leukemia, neoplastic B cells infiltrate the bone marrow, spleen, and peripheral blood. In the marrow, this characteristically leads to fibrosis and pancytopenia. Patients typically present with signs and symptoms related to these cytopenias, including fatigue from anemia, easy bleeding and bruising from thrombocytopenia, and frequent infections due to neutropenia. Many patients will present with early satiety due to massive splenomegaly that occurs as leukemic cells infiltrate the spleen. Constitutional symptoms such as weakness and weight loss are also common. Hairy cell leukemia is typically diagnosed in men. The median age of onset is around 50 to 55. On physical exam, palpable splenomegaly is a classic finding. In some cases, splenomegaly may be massive. Hepatomegaly and lymphadenopathy are not common in hairy cell leukemia. On labs, expect a pancytopenia due to bone marrow fibrosis, as depicted by this empty pan here with just a few crumbs of bait left. In 10 to 20% of cases, you may measure a leukocytosis comprised mostly of those neoplastic hairy B cells. But remember to always check that differential, which typically shows neutropenia and monocytopenia. Peripheral blood smear will show abnormal circulating lymphocytes. One of the many characteristic features is an indistinct cellular border due to the presence of little cytoplasmic projections. These give the cell a hairy appearance. A bone marrow biopsy should be performed if you suspect hairy cell leukemia. The aspirate, however, will often come back as a dry tap in the setting of extensive marrow fibrosis. So, a trephine biopsy is also performed, which takes a section of bone and marrow. Historically, demonstration of tartrate resistant acid phosphate, or TRAP activity on peripheral blood or marrow specimens was routinely used to confirm the diagnosis of hairy cell leukemia. However, TRAP has been replaced by immunophenotyping via flow cytometry, which is more sensitive and specific. Did someone say sample assessment? Mr. Bosch is a 55-year-old man presenting with fatigue, weight loss, left upper abdominal pain, and recurrent pneumonia for the last few months. His temperature is 101.1 degrees Fahrenheit. Physical exam is positive for bilateral crackles and splenomegaly. Hemoglobin is 8.7 grams per deciliter, platelets are 89,000 per microliter, and white blood cells are 47,000 per microliter. Absolute neutrophil count is 1,300 per microliter. Peripheral smear shows abnormal lymphocytes with multiple cytoplasmic projections. The patient's age, splenomegaly, pancytopenia, and blood smear results are consistent with hairy cell leukemia. The patient's neutropenic fever with crackles on exam is concerning for ongoing pneumonia. Many patients with hairy cell leukemia are asymptomatic and can be observed for months and occasionally years after the diagnosis is established before requiring treatment. Indications for treatment include significant cytopenias, symptomatic splenomegaly, or constitutional symptoms. The therapy of choice involves the purine analog cladribine. Cladribine is toxic to bone marrow, and its adverse effects include neurological and kidney damage. Pentostatin is another purine analog with similar efficacy that's an acceptable alternative to cladribine for the initial treatment of hairy cell leukemia. And that's the end of our tour. So, which artistic movement do you prefer? Modern myeloid or late lymphocytic? The choice is obvious to me, but let's briefly summarize how they compare just to be sure. CML is a hematologic neoplasm caused by the unregulated proliferation of mature and maturing granulocytes. CLL, on the other hand, is a hematologic neoplasm caused by the unregulated proliferation of monoclonal B lymphocytes that are unable to differentiate into plasma cells. In both cases, that means an elevated white blood cell count, often over 100,000. Whoa! So get that differential. In CML, neutrophils predominate. You'll see a left shift with a greater percentage of myelocytes versus metamyelocytes, the so-called myelocytic bulge, and basophils and sometimes eosinophils will be elevated as well. In CLL, lymphocytes predominate, and on the peripheral smear, you should see lots of normal appearing B lymphocytes and some smudge cells. In CML, because of the crowded bone marrow, normocytic normochromic anemia is common. In CLL, anemia occurs as well, but is less common and is usually secondary to an autoimmune hemolytic anemia. In CML, thrombocytosis is common. Counts can even soar over 600,000. While in CLL, low platelet levels may be seen, but it's rare. Again, usually due to an autoimmune thrombocytopenia. And keep in mind that CML has three phases: chronic, accelerated, and blast phase. Most patients will be diagnosed in chronic phase. Accelerated phase is associated with progressively impaired neutrophil differentiation. In the blast phase, well, you'll just see lots of blasts, either lymphoid or myeloid, just like in acute leukemia. Alright, how about presentation? Well, they both affect older adults, so we'll just call that a tie, I guess. And both are usually asymptomatic at presentation with an incidental finding on routine labs. And now that I think about it, both are also associated with nonspecific symptoms such as fatigue, malaise, weakness, drenching night sweats, and weight loss. We emphasized bleeding on the left with CML because even though platelets are often elevated, they don't work properly. On the right, we emphasized hypogammaglobulinemia because even though B cells are elevated, they don't work properly besides the fact that they inhibit the body's normal B cells. This predisposes patients to infection. In patients with suspected CML, palpate for splenomegaly due to extramedullary hematopoiesis. In patients with CLL, also palpate for splenomegaly, but as the disease spreads to lymphoid tissues, that means hepatomegaly, lymphadenopathy, and Ball-Dyer's ring involvement as well. The whole shebang. Finally, diagnosis. In CML, we use karyotyping, FISH analysis, or RT-PCR to detect the Philadelphia chromosome itself, the BCR-ABL gene, or the mRNA product of the gene. To diagnose CLL, we need a leukocytosis of greater than 5,000 per microliter. We need to see the typical small blue mature B cell morphology under the microscope. And we need to confirm that these are, in fact, monoclonal B cells via flow cytometry. And that's it. Ah, wait. Hairy cell leukemia. Okay, really fast. It involves the proliferation of small mature B lymphoid cells. On smear, they'll have that hairy morphology. These neoplastic cells infiltrate the bone marrow, spleen, and peripheral blood, causing bone marrow fibrosis and pancytopenia. Hairy cell leukemia has similar symptoms to the other chronic leukemias, except there's usually no lymphadenopathy but massive splenomegaly. Diagnosis is likely if a smear stains positive with TRAP, or you can use flow cytometry. A bone marrow biopsy is also needed to confirm the diagnosis, but an aspirate may be difficult to obtain because of the extensive fibrosis.
Hello.
Knights Templar! That was frightening. You gotta stop doing that. Okay.
Okay.
Very funny.
Very funny.
Look, imitate imatinib. I get it.
Imitate imatinib. I get it.
That's not what I sound like. That's like drunk Christopher Walken.